Hello. So in this presentation, we are going to talk about high flow nasal cannula. These are my potential conflicts of interest. And high flow nasal cannula is a new, interesting option for treating patients. And it is characterized by four major features: the possibility to deliver accurate FiO2, the provision of small amounts of positive airway pressure at end expiration, the washout of the pharyngeal dead space, and the possibility to provide warm and humidify gas mixture. Now, let's start from the last one. Warm and humidified gas, we can provide high flows of inspired gas up to 60 liters per minute, which can be fully humidified, 37 degrees, 100% of relative humidity. Now, this has been shown to have a significant impact on patient comfort. In this study, we compared interface discomfort and dryness discomfort between a Venturi mask and the high flow nasal cannula. And as you can see, there is a progressive decrease in discomfort and dryness discomfort, in interface discomfort and dryness discomfort in patients receiving high flow nasal cannula as opposed to the Venturi mask. And this effect was visible starting from, let's say, 24 hours. So when you need to apply long periods of oxygen therapy, this is really an option. Tommaso Mauri and co-workers showed that comparing the effect of the flow rate, 30 and 60, and the temperature, 31 and 37 degrees, that the best comfort was achieved with 31 degrees combined with 60 liters per minute. And this was done in critically ill patients. Let's move to the second, probably the most important part. Can be used for hypoxemic patients because of FiO2 accurate delivery and because of the provision of small amount of positive airway pressure. Again, Mauri and co-worker shown a small but significant effects on an expiratory lung volume, which was significantly increased when increasing the flow rate, and the reduction of the pressure time product of the esophageal pressure, which means reduction of the work exerted by the respiratory muscle, and at the same time, an improvement in the PaO2 FiO2 ratio. Now, the study, probably the most important study on the use of this technique was this comparison by Fratt and co-worker with standard oxygen and with NIV. When we consider the primary endpoint, there was no significant, which was a cumulative incidence of intubation. There was no significant effect of one versus the other, but high flow oxygen showed a trend toward a better performance. However, and this is a secondary analysis, there was a significant reduction of mortality after 90 days. And the authors explained with this predominantly with the concept of the potential self-induced lung injury, which was due to the fact that they assumed that the pressure added to the system was entirely used to increase tidal volume and was a potential source of self-induced lung injury because of the increased transpulmonary pressure. This notion was challenged by this recent study by Luca Grieco and co-worker, who showed that comparing high-flow nasal cannula with helmet NIV, there was a significant reduction in inspiratory effort with the helmet, and more important, they showed that the transpulmonary pressure was not, first of all, predictable and was varying depending on the single patient. So some patients increased transpulmonary pressure when applying NIV, and some patients decreased, indicating that we have probably different behaviors depending on the type of underlying disorder. And indeed, this meta-analysis by Rockwell and co-worker was not able to show significant differences when grouping all the studies performed on this technique as opposed to standard oxygen. There's no difference regarding mortality. However, they showed a small but significant reduction in the need for intubation. Let me tell you that we should consider the type of underlying disorder. This is data from Samir Jaber, published 10 years ago in anesthesiology. This is the patient before, and this is the patient after application of NIV. And as you can see, there is a significant recruitment of the posterior area of the lung when applied 5 centimeters of water of PEEP and 15 of pressure support, suggesting that there might be need for applying pressure. With Alexander Mull and Nicholas Hill, we provided a few years ago this algorithm where we propose a sequential use of high-flow nasal cannula and NIV to treat, before intubation, to treat acute hypoxemic respiratory failure. An alternative that we are studying in these days would be combining the two high-flow nasal cannula and CPAP in the same device. And in this study performed in healthy subjects, we understood that the interaction between pressures generated by the high-flow nasal cannula and the CPAP was actually pretty reasonable, and the effects shown by high-flow nasal cannula on end expiratory pressure were actually fewer during CPAP than during spontaneous unassisted breathing. Finally, important to assess the effects of high-flow nasal cannula, this index has been proposed, the ROX, which is actually the ratio of SpO2, oxygen saturation, peripheral oxygen saturation, and the inspiratory fraction of oxygen divided by the respiratory rate, which has been shown to be a good predictor for ROX values above or below 4.88. So an important tool to understand those patients at risk of failure of high-flow nasal cannula. Let's move to the third aspect, washout of pharyngeal dead space, which has an effect to manage hypercapnic patients. And we know that the effect is dependent on the extent of flow applied from 0 to 30. The white correspond to the washout, the red to the CO2 rebreathing. And Rosa Di Mussi and co-worker showed that after extubation in hypercapnic patients because of COPD, the use of high-flow nasal cannula was able to reduce the neural drive as assessed by the electrical activity of the diaphragm and the pressure time product of the respiratory muscles as neatly indicated in this slide. Also, we showed when interacting NIV that compared to standard oxygen, high flow oxygen therapy by nasal cannula was able to reduce the extent of diaphragm thickening fraction, suggesting a reduced activity of the diaphragm to achieve the same PaCO2 and the same PaO2 as during NIV. Sorry. Last, the application of a high-flow nasal cannula after extubation has been shown in a large population of patients, non in high-risk patients, in the vast majority of patients able to improve the outcome of extubation as opposed to conventional standard oxygen therapy, which is very interesting. Please remember that extubation failure is something that can dramatically affect the outcome of the patient. And the same group also showed in high-risk patients a comparison between NIV and high-flow nasal cannula, showing that high-flow nasal cannula was not inferior to NIV. More interesting, in my opinion, this very recent study by Arnaud Thiel and the RIVA, the French network of ICU, who showed that using high flow with NIV, alternating period of high flow and NIV versus high flow nasal cannula alone, there was a significant reduction of the rate of reintubation on the group of patients receiving both high flow nasal cannula and non-invasive ventilation. Interestingly, in a subgroup analysis, the subgroup of patients who showed the largest effect were actually hypercapnic patients, confirming that even in these patients there might be a role, and not only in hypoxemic patients, as we believed at the very initial stage of assessments of the ability of high-flow nasal cannula to treat our patients. And in non-hypercapnic patients, the effect was also visible, but to a lower extent than in hypercapnic. So in conclusion, the full potential of this technique have been not entirely explored insofar, but there is clearly a role for treating our patients, our critical patients, for this technique. I wish to thank you for your attention.